Hello and welcome to the Evidence-Based Urgent Care Urgentology podcast. I'm Joe Toscano. I am on the editorial board of Evidence-Based Urgent Care and also the senior research editor for the sister EB medicine publication, Emergency Medicine Practice.
And I'm Tracy Davidoff. I'm the editor-in-chief of Evidence-Based Urgent Care. Joe and I have been involved in urgent care practice and education for many years, and we're really excited to bring to you this new program from EB Medicine, the Evidence-Based Urgentology podcast. Our goal for this podcast is to review one of the recent issues of evidence-based urgent care and highlight some of the important things that have come out of that issue, the learning points and potentially practice-changing information from the piece.
We hope that the podcast will be valuable in and of itself, but it'll also whet your appetite to delve more deeply into the issue, to hone your practice, and even get some CME credit.
And even if you've read the issue already, Joe and I hope to reinforce the important points and solidify important concepts to improve your learning as a result.
If you create an account at ebmedicine.net, you can subscribe and purchase the issue. You can check out the interactive clinical pathways they have there, and you can get up to 4 hours of CME credit for completing this one issue. Hey, you've already started your CME journey by listening in.
And you can also subscribe for a full year so you won't miss anything. At the regular price, that's a great value. Be on the lookout for occasional promos, sales, and special offers to make it that much easier. Good morning, good afternoon, or whatever the time of day it is that you're listening to this podcast. We would like to talk today about evidence-based management of angioedema in urgent care. This is the May edition of Evidence-Based Urgent Care. This article was an adaptation from an emergency medicine edition. Thank you very much to the author, Laura Leah Johnson, a family nurse practitioner who works in Cape Girardeau at the VA Health Center clinic there.
And thanks to our peer reviewers, our very own Tracy Davidoff, as well as Eric Macy, who is an allergist with Kaiser in San Diego.
Okay, so this is a very important topic. You know, people walk into urgent care all the time with these sorts of things. Can't stress enough, this can be a very serious and life-threatening condition because it's really a spectrum of diseases that starts with a simple allergy where somebody has a few hives, all the way up to severe anaphylaxis, airway compromise, the whole 9 yards. So the urgent care clinician really needs to be astute about this and not say, oh, it's just hives, I'm not going to worry about it. Also, the other thing that we really need to be aware is the ACE inhibitors that can cause the angioedema, which we'll talk about a little bit more. This walks into urgent care a fair amount. Current treatments have changed a bit about back when we trained, so we're going to talk about a little bit of that. But the bottom line is you really, really need to be vigilant in deciding who needs epi emergently and who should be transferred to the emergency department for observation and further treatment. So if you get nothing else out of this podcast, be very astute about who needs epi and do it as soon as possible. Joe, can you start us off with a review of the etiology and pathophysiology of angioedema, please?
Sure. So angioedema basically involves swelling of the soft tissues. We're familiar with it involving the face, the lips, the mouth, the throat, the uvula, the oral pharynx, but it can actually also involve the extremities, the hands and fingers, and even the genital area. Different than urticaria, where the edema is in the cutaneous tissues. With angioedema, it's in the mucosal tissue, submucosal or subcutaneous layers of the skin, or in the connective tissues, and that's how people get their symptoms. In terms of the underlying pathophysiology, angioedema can be characterized in a number of ways based on that pathophysiology. It can be mediated by histamines or bradykinins. And then finally, there's stuff that we don't know, and there's idiopathic angioedema as well. Histamine-mediated angioedema is the most common, probably accounts for an estimate of between 40 and 70% of cases. It usually develops rapidly over minutes to an hour or so. And a lot of times there's associated itching, and it can even co-occur with urticaria. The final common pathway after histamine release is the binding of histamine to H1 and H2 receptors. And then that's what produces the symptoms. Bradykinin, a little more complicated in terms of the pathophysiology. Bradykinin is a vasoactive peptide. It's part of the kallikrein-kinin symptom. Remember that from medical school? I don't even remember that. Anyway, the interactions in that cascade are a little bit more complicated and actually involve some blood clotting components, including factor 12A, plasminogen, and endogenous plasminogen activators that we have. But the end result is inflammation and edema, not really triggered by an allergic reaction. And the progression with bradykinin-mediated angioedema is typically slower, developing over a period of hours to days. One of the examples of this is the familial or hereditary angioedema that we can see, and that's genetic in origin. There is also an acquired form of angioedema that's in that bradykinin-mediated pathophysiology, similar to hereditary angioedema, though people aren't born with it, and it's actually a hematologic disorder. where there's a overdevelopment of the cells that produce those hormones. I think the classic thing that we're taught to recognize is ACE inhibitor angioedema with swelling of the tongue in a patient who's taking those meds. That is an example of bradykinin mediated angioedema. It's one of those classic presentations that we're taught to recognize. Talking a little bit more about that, it's actually not a dose dependent reaction. It actually can occur a few hours after the patient takes their first dose or even up to 10 years after they've been on the medication. So sometimes it can be hard to trace it to that. It's estimated that that form of angioedema occurs in zero point 0.1 to 0.7% of patients who take those medications. And the risk is known to be actually 3 to 7 times higher in African Americans. I actually didn't know this, but learned it from reading the issue that other meds can be associated with bradykinin mediated angioedema. And it can even be NSAIDs, which I typically think of as being histamine allergic type reactions that people get, estrogen and estrogen containing products, and some antibiotics, and then some less common meds that patients are on, like cyclosporin or direct renin inhibitors, such as Alisk, and then some rarer medicines that diabetic patients are on, the gliptins. The issue talks about angiotensin receptor blockers, which are like that next generation of ACE inhibitors. And actually, the evidence is a little bit difficult to discern. The medicines are similar in terms of their biochemistry. And there's some evidence that switching a patient from an ACE inhibitor who's had this sort of a reaction to an ARB probably is okay to do. But there's also some evidence where it's not that clear. There was a large study that showed that patients who had ACE inhibitor related angioedema also had reactions to ARBs. So just need to be careful about that. I don't think we know the exact answer. And then just like everything else, there's some stuff that we don't understand and that gets lumped together in idiopathic angioedema. And you really only know that when you determine it's not bradykinin mediated or histamine. And sometimes just in retrospect, when the patient fails to respond to treatment for either of those two. It's a lot going on biochemically. What's in your differential for angioedema for these patients, Trace?
Well, I mean, if it's straightforward, it's either on that spectrum where it's urticaria, angioedema, anaphylaxis, that sort of thing. But sometimes it can be a little difficult to try and figure it out. By all means, I'm going to say this again. If it's an emergent, treat first, ask questions later. If
Mhm.
you think the patient's having any airway compromise or you think this is heading for anaphylaxis, you're going to want to treat them and ask the questions later. Obviously, we just talked about the histamine and bradykinin and the ACE inhibitors. Back in the day when I worked in the emergency department, one of my most scariest angioedemas was an ACE inhibitor, and she
Mhm.
ended up trached. So it can be very, very scary. But, some people are like, gee, I'm not really sure why my eyelid is swollen. So bug bite, they may think that they have had a bug bite or something like that. They could have a local allergy to something that they touched. A lot of times with hot peppers, capsaicin, things like that can kind of mimic angioedema, cellulitis. Some people may think they have a skin infection, trauma. They may not remember having some sort of trauma that caused redness, swelling, and stuff that looks like angioedema. Other weird syndromes and diseases like filariasis, if anybody remembers that from school, where the worm gets into your venous system and causes edema distally. So you may have to ask a lot of questions to figure it out. I always ask about, has this happened before? Were you exposed to something that's caused a reaction similar in the past? Is there anything new at home? Do you have a new pet? Did you take a new medicine? Any of those sorts of things. And a lot of times you never figure out, what the etiology of it was, but, you still need to ask all the questions. What do you look for in your H&P, Joe?
Well, unless you're sending off serum complement levels for screening for hereditary angioedema, this is all about the H&P. You're right. Classic urgent care medicine. You may get that patient who knows they have hereditary angioedema, or maybe they're having their first episode, but they know they have it in their family. And you can kind of peg it as that. Or if a person's had a similar reaction to a known allergen in the past, that kind of makes it easier. And sometimes they'll come in volunteering that information, but sometimes you have to sort it out, like you said, asking questions about exposures and other things like that. As I had mentioned, the rate of progression can be helpful in distinguishing between whether it might be histamine related or bradykinin related. Usually, if it's rapid, it's going to be histamine mediated angioedema. If there's a co-occurrence of urticaria, that puts it more in that category. Of course, somebody recently starting an ACE inhibitor should perk up your spidey senses about it probably being bradykinin mediated. Maybe antihistamines won't work. But also, again, NSAIDs or estrogen containing products or really any new medication could be either histamine mediated or bradykinin mediated. We know that nausea and vomiting can occur with histamine mediated angioedema a lot of times, but it's actually the case that abdominal pain or even abdominal swelling is more likely with bradykinin mediated. And then if the patients experience some swelling of their fingers or limbs or genitals, that's more likely to be bradykinin related. As far as exam, of course, you want to run through your ABCs and intervene if there's any compromise in those. You want to examine the face and oral pharynx, looking for swelling of the eyelids, lips, tongue, sublingual area. Of course, examine the skin more than just the face for urticaria. That can be a clue. You want to listen to the lungs for stridor or wheezing that could trigger a diagnosis of anaphylaxis and reaching for that epi. Short of a patient obvious distress, there is some potential prognostic significance based on the location of the edema that the patient is experiencing. The issue cites an interesting study by Ishu et al., published back in 1999. Actually, the study took place over 11 years, but they developed a staging system for angioedema based on location, and it had a predictive value. Stage one was either facial or lipedema, or maybe a facial rash, so kind of the mildest symptoms. Stage two went into the mouth and involved edema of the soft palate. Stage three, patients had tongue edema. And then stage four was laryngeal edema. Like, you think anatomically, that's getting worse and worse over time. They had 80 patients in their study with 93 episodes of angioedema over that time. They found that none of the patients with stage one or stage two edema required any airway intervention or ICU admission at any time in that 11 years. And then, as you could surmise, the worst patients, or those are patients with edema closer to the larynx, did worse. Most of the stage three and all of the stage four patients required ICU stays. And of the patients who had that stage three edema involving their tongue, about 7% eventually required airway intervention, and 24% of those with stage four or laryngeal edema did require some type of airway intervention. So the location of the angioedema sort of makes sense anatomically. The closer it is to that inflow to their lungs, the more important it is to pay attention to it. So you're thinking your patient has angioedema. What's our go-to for treatment for these patients?
So without a doubt, the first step is if you have any concern about anaphylaxis or airway compromise, you're reaching for that epi. Some clinics actually have EpiPens. Some clinics, have to draw it up and inject it themselves. I strongly advise you to figure out where your epi is in your clinic, how it has to be administered, and what you have to do. I recently changed jobs and I was unaware that they had EpiPens instead of the regular, epi. And the nurse hands me the EpiPen and I didn't know what to do with it. I had no idea how to open it, how you trigger it, how you inject it. And the patient looks at me and he goes, "Oh, come on, doc." And he whips it out of my hand and he jams it into his thigh. I was so embarrassed.
No worries.
So absolutely make sure you know where it is and how to use it. A lot of places, and I strongly recommend this too, have an allergy box. It can be just a little container or a little shoebox even that has the supplies in it that you need to emergently treat somebody with epi. So you don't have to go grab that huge grass cart. You just grab that little bag, envelope, box, whatever it is, with your anaphylaxis cart or your anaphylaxis box. So you have it ready to you. And, you're going to want to resuscitate and transfer as possible. This is not somebody you're going to keep in your urgent care.
Mhm.
There is a whole lot of reluctance to give epi. A lot of people are afraid of it because of issues of hypertension or coronary artery disease, or, they're just afraid of it. Get over it. If you truly, truly need it, you need to give that epinephrine. So treatment, if you think it's ACE inhibitor related, or if you think it's another kind of bradykinin induced angioedema, stop whatever drug it is if the drug is involved. And generally the angioedema will go away and won't come back unless the patient's exposed to whatever that is again. So sometimes all you have to do is withdraw the medicine. Keep in mind, there's really no treatment for the bradykinin induced that's due to ACE inhibitors. If it's familial or hereditary, most patients will know about it and know what they need to do and will basically tell you. There is specific medicines for them, but this, obviously is not something we're going to stock in urgent care as it doesn't come up very frequently. More on that is really kind of beyond the scope, just to keep in mind that nothing nothing works for bradykinin induced
Mm.
except tincture of thyme. So the histamine induced. So acute treatment, if it's really emergent, you're going to give that epi. And then we worry about what's called short-term prophylaxis for recurrence. So we don't want them to get any worse while they're sitting in our urgent care. And then long-term prophylaxis, meaning preventing it in the next few days over weeks. Remember, if it's something the person ingested that caused it, you got to wait till whatever that allergen is gets through your entire GI tract. And the half-life on a lot of these things, the half-life on diphenhydramine is about 4 hours. The half-life on epi is about 3. So if it's something that you're continually being exposed to in your GI tract, that's going to wear off and you might rebound again. So it's something you're going to have to keep medicating for. So, like I said, remove the trigger. You want to try to give a long acting antihistamine. These have actually been proven to be better in the long run than your diphenhydramine, again, because of that short half life on it. Cetirizine can be given IM or PO. Who knew? There actually does exist a parenteral form of cetirizine. And if you have that available to you, that's probably better. If you don't, then I think you're stuck with the diphenhydramine. These are second line for anaphylaxis. So after you've given your epi, you can give these. But if you've decided that you don't need to give your epi, then this is where you're going to start. You will frequently need to redose your antihistamine. So make sure that you're aware that it needs to be given every 4 to 6 hours. A word about the cetirizine. We're not using standard allergic rhinitis doses for this. We're actually going to double the dose. So you're going to use 2 times the normal dose for seasonal allergies. So you can either do 2 pills of the cetirizine at the same time, or what I'll frequently tell patients is to take it morning and night so that you kind of keep a steady state in your bloodstream to keep that reaction from returning once it's abated. H2 agonists, famotidine, which is probably the only one available over the counter these days. There's no proof that it works for angioedema, but there is proof for urticaria. So if you have somebody that has angioedema and urticaria, you're probably going to want to give the famotidine as well. So, Joe, one thing that I haven't mentioned is steroids. So, what's the deal with steroids and angioedema? Are they necessary? Are they optional? Should we be giving this? Should we not be giving this?
Well, we're hearing that steroids are part of the next stewardship effort, and it actually spills into this topic. Though we see them being used quite a bit, I think, and it's kind of been part of the tradition for a long time, there's actually no evidence that they help change the course of acute angioedema. And we do know that there's quite a bit of evidence of the potential harm of these meds. So I think we can say it's best and safest to not use them routinely. How about controversies and cutting edge on this topic?
Just another thing about steroids, I was always taught that you only give steroids if they're wheezing.
Uh-huh.
So that might be one reason why you would think more about giving steroids. But you're right, most of the evidence has not been favorable for giving steroids for anaphylaxis or angioedema.
Yep.
Okay, so I think the steroids are controversial, obviously, if you're going to ask me about controversies and cutting edges. Then we also have the leukotriene receptor agonists, things like montelukast and the similar medications for that. Intuitively, it's reasonable, works for allergies. Maybe we should use it for this. But the studies are very, very lacking in this. And the ones that there are very inconclusive. So kind of jury's out on that one. Tranexamic acid, that's been floating around for a while for a bunch of different uses. Why it's not really catching on for things, I'm not really sure. But there's some thought that it will work for the histamine mediated as well as the ACE inhibitor edema. What this does is it inhibits the conversion of plasminogen to plasmin. So this is key to the generation of bradykinin. There's been a few studies on this. The results are kind of mixed, but it's very affordable and it is recommended in some studies. So in some cases, like if you have the really bad angioedema from the ACE inhibitor, might be better than nothing in some cases if you have that available to you. So, Joe, how do we decide on disposition? Are we going to send people home? Are we going to send them to the ED? How do we decide who goes where?
Well, time is kind of the answer here in which direction the patient's going. After you've instituted any initial treatment that you think the patient needs, you just have to watch them for a bit. There's no guarantee, but in general, if they look like they're getting better, they should continue to. I mean, that's all you have to go on. And if they're getting worse, you need to get them out of there and get them to the ED. In general, the recommendation is to actually make sure they're doing well for 4 to 6 hours. So part of that period may be the time before they get to urgent care. So you can factor in maybe an hour or so in the clinic and know that they're continuing to do okay. Sometimes it's hard to watch somebody for that long in the clinic. So you have to kind of factor that in. Thinking back to the issue study, if their angioedema is limited to the face or the lips, you're probably going to feel more comfortable at some point sending that patient home versus if their tongue is swollen, or certainly if they have stridor or evidence of laryngeal edema. And then, of course, anybody that you send home, you want to make sure you have them set up with meds if it's histamine related angioedema, ongoing doses of H1, H2 blockers, and then make sure they really understand their return precautions. And if they take a turn for the worse, they need to call 911 to take them to the ED.
It's generally my habit to send anybody I've given epi to the emergency room just because one, I don't really think I feel comfortable watching them for 4 to 6 hours.
Mhm.
My clinic does not staff with RNs. We only have medical assistants, and I'm not so sure that the level of their training is up to watching somebody that I just gave epinephrine to. I know some clinics do have that ability and can observe people a little bit better. What are your thoughts on that? Do you think everybody that's had epi should probably go to the ED, or is it safe to watch them in your urgent care?
I would probably say you're right. I think if you're reserving that medication for the patients with the worst symptoms to begin with, then Those are the ones that if they have a recurrence or rebound, it's going to be bad. Most of the patients just in general, and most of the patients we see in urgent care are type 1 patients, maybe eyelids and a little bit of lipedema. And those are going to be the ones who are going to do the best. Once you start talking about a swollen soft palate or uvula or tongue, those patients are scarier kind of right from the start. You might institute some initial treatments and then move them along. But a patient with really mild symptoms that it's more superficial, probably not going to get epi initially, maybe observe them for a few hours and send them home with precautions. But anybody who gets the epi, you're right. You're giving it for a more profound presentation to begin with, and that patient's going to be a riskier patient.
Right. Thanks.
Yeah. Hey, you want to lay on some points and pearls?
Absolutely. So the
All
biggest pearl is always assess for emergency conditions first, last, and always. Airway, anaphylaxis. Either of those things, treat first. Epi, epi, epi. Cannot stress it enough. The worst thing you want to do is sit there and think about it and then have the person go down the tubes on you. Got to give that epi if it's indicated. If their voice has changed, if they've got that swelling of the soft palate or uvula, if it seems like their blood pressure's starting to tank and their heart rate's starting to go up. A lot of times they'll say, "Oh, I don't feel so good. I think I'm going to pass out." Any of those things, treat with that epi. Absolutely. You don't want to be in a position where you have to do CPR or worry about an airway. Once you've ensured stability, you can activate EMS, or if you decide that it's something that you're going to keep in your urgent care, you can get your history and your other treatments later. Remember, classification dictates your treatment. So if you've got histamine mediated, 40 to 70% of what we see is going to be that histamine related. It's got that rapid onset, not a delayed onset. And a lot of patients will also have that urticaria. You see the urticaria and the patient tells you it started within just a few minutes. It's a pretty safe bet it's histamine related, and you can go down that pathway or algorithm.
Mhm.
Bradykinin mediated, again, you pointed out very slower onset. It's usually not triggered by anything. Patients may have a family history of it, or they may have taken an ACE inhibitor or some other medicine on that list. And remember that the ACE inhibitor, bradykinin mediated angioedema can occur even up to 10 years after you started that dose, but most occur within the first few weeks of the initial dose. And remember that Black patients and women are generally at the highest risk for the angioedema related to the ACE inhibitors. And how about some treatment summaries, Joe?
Well, epi, 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 just like you said, for those patients who need it. I don't know if it's embarrassing because there's nothing I can do about it, but I started medical school almost 40 years ago. And on my first rotations, which was what, maybe 38, 37 years ago, we used to use epi for urticaria in the
Yeah.
ED rotations. Patients would come in with urticaria, little kiddos, and we would give them epi for, what you would consider a relatively minor allergic presentation. It always worked. And then you throw in some antihistamines afterwards. It was probably more than we had to do. And I think now epi is reserved for those patients with more severe symptoms. But we don't need to be afraid of it. And if the patient needs it, they're going to get way more benefit than any potential for harm. I heard, actually at the conference, somebody had a good mantra for when to give epi. And what they basically said was, if A, B, or C, then do E. So it's A, B, C, D, E. And that's basically if a patient has some type of allergic reaction, whether it's, urticaria that also involves these symptoms, or angioedema involving these vital structures. If it involves their airway, their breathing, or their circulation, so wheezing, stridor, airway compromise, hypotension, then those are the patients you're going to give epi to. And then, like you talked about, I think you want to max out on your antihistamines, H1 blockers, sometimes in double the dose, sometimes more than that. I saw a patient actually in the ED recently who was seeing an allergist for refractory urticaria and was taking triple dose loratadine in the morning and double dose cetirizine in the evenings, along with famotidine. And it was just keeping her symptoms under control while they were trying to
Wow.
figure out what next to do. Yes. And, those medicines are marketed in reasonably low doses so that they're non sedating. And we found that you can kind of increase the dose and get increased effect and do that safely. For treatment also, if it's an ACE inhibitor mediated, or if the patient's even on an ACE inhibitor and they're having angioedema, it's probably going to want to stop that med. But also think about other medications that's possibly being related to angioedema as well. It could either be histamine or bradykinin mediated. And if it caused it that first time, likely to cause it again. So if it's suspicious, you want to stop that offending medicine as part of the patient's treatment. And how about wrapping up with some pearls, Tracy?
Okay. So one more time,
Yeah.
assess for airway and anaphylaxis. Actually, it's not going to be one more time. I'm probably going to say it again. Don't delay your treatment if the patient's unstable and getting a detailed history or physical because you don't need them to go down in front of you. Medical emergency. Transfer for any signs of airway compromise, any swelling of the posterior pharynx, the tongue, change of voice, that's a big one. And don't fear the epi if it's really needed. Remember, drugs don't work in bradykinin mediated angioedema. Just cross your fingers. It will go away spontaneously if it's drug induced. Probably need to send them to the ED if it's hereditary or if the angioedema is significant related to the ACE inhibitor, just for monitoring. Sometimes they need to be monitored for 24 hours to make sure that swelling goes away. Don't forget, GI tract can also be involved and can cause nausea, vomiting, abdominal pain, and this can actually mimic an acute abdomen. So if you have somebody that's got some angioedema and some belly pain, think about that as potential for angioedema actually occurring in their GI tract. So some final pearls from you, Joe?
Yeah. Well, steroids, remember, steroids are really not helpful in the acute treatment of these patients. Your hereditary and bradykinin, I know the bradykinin mediated angioedema patients are a little bit more tricky. The treatment's more involved. We don't have the meds to do it. So those patients are probably going to be best sent to the ER to kind of sort that out. Of course, if you think it's histamine mediated, go for it. You know how to treat that. And of
Yep.
course, remember, don't
Don't
fear
fear the epi.
orthopedic.
If they need it, you got to give it.
Absolutely. Well, thank you for listening. This was fun. And we do have some information about a timely promo. EB Medicine just launched the Abscess course with Dr. Patrick O'Malley. This course prepares you to diagnose and treat all kinds of abscesses, from chalazions to paronychia, anywhere in the body from head to toe. It includes plenty of video demos, 5 CME credits, and a free incision and drainage practice kit. Go to ebmedicine.net to learn more.
It's a really cool course. I looked at that.
Yeah.
It's very cool.
Yeah.
The abscess actually really oozes out when you cut into it. It's very cool.
Oh, wow. Gosh. Yeah, Patrick's stuff is great. And then the key points and clinical pearls from all of EB Medicine's 2023 topics in urgent care and emergency medicine are now available together in a searchable digital format. For a limited time, new subscribers to EB Medicine Complete Bundle get the Points and Pearls 2023 Year in Review for free. And that's a $397 value. Go to ebmedicine.net/subscribe.
I want to thank everybody for listening to this month's evidence-based urgentology podcast. Just a reminder that subscribers can go to ebmedicine.net and read the full issue if you want more information, if you haven't already.
And if you're not a subscriber, head to the site, that's ebmedicine.net, to check out what they have. If you subscribe, you'll get access to the article, as well as future articles and the whole archive of all past issues.
Look forward to seeing you there.